Welcome to The Explainer. Today we're unraveling a true crime-style medical mystery. And the crime scene, it's right inside the human body. We're going to examine exactly how microscopic invaders, we're talking everything from stealthy single-celled assassins to literal physical blockaders, manage to breach our internal defenses and attack one of our absolutely most vital organs. So to set the stage here, think about this. What in the world do a tropical vacation, an innocent little cat scratch, and anchovy paste have in common? I know, it sounds like the setup to a really bizarre joke, right? But the punchline is actually the liver. These are all vital clues pointing to the fascinating, sometimes totally bizarre, and incredibly stealthy ways our internal fortress can get compromised. Okay, let's dive right into our roadmap for today. First, we'll look at the liver under attack, then the amebic assassin, followed by parasites of the biliary tract, a bacterial rogues gallery, and finally, the medical counterattack. Kicking things off with part 1, the liver under attack, the fortress and the breach. You see, to understand the crime, we first really need to understand the fortress itself. The liver is an absolute powerhouse. It essentially acts as your body's primary filtration plant. It's the very first site that filters all those absorbed intestinal contents. But here's the catch. That exact vital function is what makes it so incredibly vulnerable. Because it sits right downstream from the gut, taking in this massive blood flow via the portal circulation, pretty much any pathogen that manages to breach your intestinal wall, well, it gets funneled straight to the liver. It is right there on the front lines, which makes it highly susceptible to a whole host of microbial antigens. Which brings us to section 2, the amebic assassin, Entamoeba histolytica. Now, let's meet our primary suspect. Look at this number, 40 million. That is the staggering number of infections caused by Entamoeba histolytica globally, every single year, and it leads to upwards of 100,000 deaths. It's especially prevalent in regions with poor sanitation or unsafe municipal water supplies, places like India, Africa, Mexico, and parts of Central and South America. So the crucial point here is that, well, not all amoebas are out to get you. Entamoeba histolytica actually has cousins, like Entamoeba dispar and Entamoeba moshkovsky, which can also infect humans through the fecal-oral route. But those cousins, they're totally non-pathogenic. They're basically just harmless passengers that might leave you as an asymptomatic carrier. Entamoeba histolytica, on the other hand, is an active, downright dangerous threat, and it's the one responsible for clinical amebiasis. Let's track this invader's stealthy, Trojan horse-style invasion. It all kicks off at minute 1 with the ingestion of microscopic cysts, usually from contaminated food or water. By hour 2, these cysts hit the small intestine and undergo excistation. Basically, they break out and release these active motile forms called trophozoites. Now, fast forward to week 1, and they aren't just hanging out. They are actively adhering to and destroying the colonic epithelium, literally invading the tissue. And then, around week 4, these trophozoites hijack your portal circulation. They ride the bloodstream straight into the liver, where they set up shop and start causing inflammation, necrosis, and eventually abscesses. You know what's truly terrifying but also kind of amazing about this organism? Its toxic efficiency. The sources reveal that inside these massive liver abscesses, there are actually relatively few of the organisms themselves. What this suggests is that Entamoeba histolytica trophozoites can mediate hepatocyte destruction, basically forcing your liver cells to die or commit cellular suicide without even needing to physically touch them. They are quite literally projecting their toxic damage from a distance. No way, right? So what's the actual result of all this tissue destruction? Well, if a doctor performs an aspiration on one of these amebic liver abscesses, they extract this thick, completely odorless, chocolate brown fluid. And in the medical literature, this is classically described as anchovy paste. Yeah, let's just say after learning that little fact, you might want to permanently skip the anchovy paste on your next culinary adventure, for sure. Moving on to section 3, parasites of biliary tract, the blockaders. Okay, let's shift our focus from that stealthy amoeba to a very different kind of microscopic invader. We're talking about parasitic worms that specifically target the biliary tract. These guys, like the nematode Ascaris or trematodes like Clonorchus and Fasciola, they take a total brute force approach. They cause severe damage through direct chemical irritation from their eggs and secretions. Plus, they physically block the bile ducts, literally like clogged plumbing, which then induces the formation of biliary stones. But honestly, their most insidious tactic? as they migrate from the duodenum up into the biliary system, they literally drag other bacteria along with them, introducing secondary bacterial infections straight into the liver's delicate network. It's a double whammy. And that leads perfectly into Section 4, a bacterial rogues gallery, breaching the walls.
Speaking of bacteria, when they do manage to breach the walls of the liver, they leave behind these highly unique fingerprints. Now, what's really interesting about this is just how specific the liver's reaction is to different bacterial villains. For example, Salmonella typhi, which causes typhoid fever, creates these characteristic typhoid nodules because of a massive proliferation of Kupffer cells. Then you have Yersinia enterocolicaita, which absolutely loves environments with excess iron. That means people with hemochromatosis are actually at a much higher risk for Yersinia abscesses. Next up, Coxiella burnetii, which you can inhale from animal dust. It causes Q fever and leaves this incredibly bizarre signature called fibrin ring granulomas. And then there's Bartonella henselae, the bacteria behind cat scratch disease. It can cause peliosis hepatis, forming literal blood-filled cysts inside the liver, especially in immunocompromised patients.
Oh, and we definitely can't forget the gonococcus bacteria. A disseminated gonococcal infection can actually cause something called Fitzhugh-Curtis syndrome. Basically, this is a perihepatitis, which is inflammation around the liver, that causes this sudden, incredibly sharp pain right in the upper right quadrant. It closely mimics a gallbladder attack. But a really savvy clinician can identify it by listening for a characteristic hepatic friction rub over the liver. That friction rub is the giveaway, proving the pain isn't actually the gallbladder at all, but rather an extra hepatic infection.
All right, Section 5, the medical counterattack, diagnosis, and cure.
This brings us to our final act. How exactly does modern medicine identify and defeat these invaders, specifically our main suspect, the amebic abscess? Well, diagnosis always starts with a good old-fashioned detective work. Getting a travel history to endemic regions is absolutely critical here, even if that travel happened months or literally years prior. Next, clinicians bring out the advanced imaging. An ultrasound is going to reveal these round, hypoechoic masses, while a CT scan typically shows a low-density lesion with this glowing, enhancing peripheral rim. But the real smoking gun? That's serologic testing. They check the blood for specific antibodies to the amoeba, and amazingly, this boasts a sensitivity of over 95%. So let's see how this shapes our actual treatment protocol. The medical strike against an amebic liver abscess is a very strict two-step process. First, you have to attack the tissue invaders currently in the liver with the nitroimidazole, like metronidazole, for about 7 to 10 days. But because the amoeba continues to colonize the intestine in roughly half of all cases, you absolutely must follow up with step 2. That means prescribing a luminol agent, like paramomycin, for an additional 7 days just to eradicate any of those cysts still lingering in the gut. But listen up, because here is a massive clinical warning drawn straight from our source material. These two drugs must never be administered simultaneously. Why not? Well, it's because the luminol agent, paramoycin, frequently causes diarrhea as a side effect. If you give it at the exact same time as the primary treatment, and then the patient develops diarrhea, the doctor won't have a clue if the treatment's failing and the infection is actually getting worse, or if it's just a routine drug side effect. So stepping the treatments is absolutely necessary to accurately assess if the patient is actually recovering.
And this brilliantly illustrates a key point. While pills work for most people, sometimes the fortress requires manual intervention. Actually, about 15% of patients don't respond to medication alone, so doctors must step in to physically drain the abscess if it's over 5 centimeters or if it's located in the left lobe. That left lobe location is especially dangerous because it carries a really high risk of rupturing right into the pericardium around the heart. Drainage is also totally mandatory if the patient fails to improve after 5 to 7 days of antibiotics, or if there happens to be a secondary bacterial co-infection hanging out inside the abscess. So we've tracked the assassins, we've uncovered the blockaders, and we've explored the medical arsenal used to fight back. But it leaves us with a lingering thought. Knowing the incredibly stealthy and hidden mechanisms of these microscopic invaders, how secure is your own internal fortress going to be the next time you eat, drink, or travel to a new destination? Thank you so much for exploring this medical mystery with me today on This Explainer. Stay curious and stay safe.